So everybody, my name is Sharon Whiteman. I'm the CEO and president of the Lyme Disease Association of Australia, and am stubbornly and fiercely committed to helping Lyme disease in Australia have a better outcome should they get bit by a tick or another insect and become sick. Today we have the great privilege of having Dr. Stephen Harris. As you know, there's about three main choices in Australia for getting your blood tested for tick-borne diseases. And today the topic is going to be about IgeneX, and Dr. Harris is very well placed to advise us about those tests. So Dr. Stephen Harris has been in private practice since 2001. He's a medical doctor. He's board certified in family practice. His private practice was opened as a sole proprietorship until 2006, after which he formed a California medical corporation, Pacific Frontier Medical, Inc. Since 2001, Dr. Harris focuses practice on the diagnosis and treatment of chronic complex illness, including Lyme disease, other tick-borne co-infections, as well as myalgic encephalomyelitis, chronic fatigue syndrome, fibromyalgia, autistic spectrum disorder, chronic inflammatory response syndrome, mold, and mycotoxin illness, amongst others. In his approach to these conditions, he incorporates strategies found in conventional, functional, and complementary medicine. He believes there are many effective treatments available for those with chronic and persistent infections. Dr. Harris has a longstanding commitment to support and advocacy for Lyme patients. He's spearheaded favorable education, protecting patients' rights in the US, and fostering continuing public health education. Dr. Harris is a board member of ELADS, the International Lyme and Associated Disease Society, the Professional Medical Society of Physicians and Scientists, which has become the authority on effective treatment for chronic Lyme disease. So Dr. Harris, I know you have such a busy schedule. I'm very grateful that you've given us some of your time today.
My pleasure. Thanks for having me.
Okay, so as I said briefly in the beginning, at the LDA, we support patients by distributing Armin Labs kits and IgeneX. We don't recommend one lab over another. Australian Biologics already has a great system for answering patient questions. Armin Labs has a questionnaire to assist you in making your choice if you're getting your blood tested there. But IgeneX, we require a medical doctor to give that advice. And Dr. Harris has gratefully, I'm grateful that he's given us approval to go forward and be able to assist you in making decisions. Because as we know, most Lyme patients in Australia now do not have a doctor to go to ask these questions. So I think first, Dr. Harris, if you don't mind, just cover in general some best practice ideas about getting diagnosed for tick and other vector-borne diseases.
So, there's a kind of funny saying that says that Lyme disease is a clinical diagnosis until you make it. And it's interesting because it is truly a clinical diagnosis, and the labs are meant to support the diagnosis that that the physician or other provider believes that the patient has, taking into account the likely exposure, the exposure of ticks to various spirochetes, and the prevalence of that in various areas, the signs and symptoms that go along with after the tick bite, if the tick bite's even known, which it often isn't, and basically keeping an open mind, and then using tests as support of that diagnosis, but not the end all and be all of diagnosis. That being said, there has been moves in this country, as well as from what I understand in your country, to make it somewhat difficult to actually get a diagnosis, and that the diagnosis has become for many doctors, and in our case insurance companies, and for getting proper treatment, getting any treatment, has become very dependent on blood tests primarily, or tissue tests. So while there's a clinical diagnosis, meaning that what's the likelihood that you have it, how do you feel, and all that, the blood testing has become very important for even getting a diagnosis. And the hard part is, and the rub is really that the typical standardized tests that are being offered to patients they have really low sensitivity, not just low specificity, but low sensitivity, meaning that it's really hard if someone actually has Lyme to test positive. And there's lots of reasons for that. The organism has really amazing ways of staying hidden. It has really incredible ways to prevent the body from acknowledging the infection. And most of the tests that we use are based on the body's acknowledgement of the infection, or typically antibody testing. So if we just use a screening test, which is an ELISA test, which measures the quantity, the overall quantity of antibodies, we're going to miss most cases, especially if someone has been infected for more than 3 to 6 months. So if someone has been recently bitten, then that ELISA, or what's also called an IFA, an immunofluorescence assay, if the test is performed right away after a known tick bite, then there may be as high as 60 to 70% positive for that part, which is still remarkably low. That 30 to 40% in the best conditions are still going to test negative. And so we're usually not seeing the best conditions. We're usually seeing long delays before someone even knows, or before someone can get treated. Sometimes under treatment early on, when there's a tick bite and a provider gives a day or 3 days of antibiotics. Sometimes that's would be enough to block the immune response, so the body isn't going to be aware and people will test negative, but it's usually not going to be enough to actually treat the infection itself. So it does sometimes more harm than good to give just a one course of antibiotics. And this is up for debate quite a bit, and is considered standard of practice in this country, but the evidence is somewhat appalling. So that being said, there are several labs around the world that do very decent testing for tick-borne disease. And Armin Labs does great T-cell testing, and some other testing, and IgeneX, which I've been a part of for several years, in one shape, way, or form. They also do remarkable testing, both for Lyme disease, for tick-borne relapsing fever, as well as for other co-infections such as Babesia species and Bartonella species, anaplasmosis or ehrlichiosis, and a few other infections as well, some that are not tick-borne. But and then there's a few other labs also that I use. One is Infecto Lab, which is related to Armin Lab here in the States, and Galaxy Labs as well, and another lab that's similar to Galaxy that does some RNA testing called T Labs, also on the East Coast of the United States. And then there's a few other labs that do fairly decent work. And labs such as Stony Brook have fairly good specificity, meaning that if it's positive, it's likely that the tests are real, but pretty low sensitivity still. So there's several labs that I work with in addition to IgeneX. I do feel that IgeneX is probably one of the standards for having the highest sensitivity and specificity. But this is not a talk about necessarily IgeneX. This is talk about testing in general. And so it's I think what's important to remember is that there's screening tests that many of these labs offer, and that many local labs may offer, such as what I had stated before, the ELISA or IFA. But unless you're doing an immunoblot or a Western blot, looking at it's a qualitative, more of a qualitative test than a quantitative. Borrelia does not induce the body to make a lot of antibodies in an absolute sense. But if you look for the specific antibodies, if you look for these various proteins that we would make antibodies against, then the testing can be pretty good, especially if if more than one strain, more than just the lab strain and East Coast of the United States strain is being utilized for the testing, then the test can be pretty good. So a starting place, just to finish up, would be to do an immunoblot, both an IgM and IgG immunoblot from IgeneX, or a Western blot from other labs that includes the various bands, that doesn't just report the positive bands, that actually looks at all of the bands that are tested.
Okay, perfect. And so in Australia, obviously people who've never encountered tick-borne diseases, you go to the doctor and you get a blood test and you get a diagnosis. And you've just, clearly explained that sometimes you could have Lyme associated diseases and not have a positive blood test. And so you need a discerning clinician to assist you with that. So the purpose today is, if someone has chosen or has had advice to use IgeneX, how would they look at the form and choose from their clinical situation, from what symptoms they have, or what would your advice as a doctor if you don't have a doctor? Where would you start? And the other thing is that there's obviously for some people budgetary constraints. So do you prioritize testing over getting started on treatment from the clinical picture? Those are big decisions for people especially people are brand new to our situation.
No, it's a hard point to address, because there's ways to test that just scratch the surface of what's available out there, and things that can affect treatment. And it's also, in a large country like Australia, there's going to be so many different regions that have a higher infectivity rate of those ticks. So if there's ticks in most regions, there may be 3% of the ticks are infected in some places, and maybe up to 15 or 20% in other places. So it's difficult in the States, or at least in California and the Midwest. If someone gets bit by the proper tick, many providers are going to treat, and they're going to usually treat first and ask questions later, because the timing is so important. And if they treat for long enough, then the testing definitely becomes secondary, because even if it does seem that even if people are infected with co-infections, so not just the Borrelia spirochete or the relapsing fever spirochete, but if they're infected with Babesia and Bartonella species, then if one treats just for Lyme, even very early, it's unlikely that those co-infections, they don't actually respond to the basic Lyme treatments. It's very likely that they're not ever going to become an issue. So the early treatment is probably the most important piece. And it's difficult unless there's tick testing done to actually establish the prevalence of that. And I know that there's been various studies that have been small pilot studies over the past 20 years or so. And I don't know what the latest is with various regions in Australia, but that's important, because then you can do a more thoughtful risk-benefit analysis on the risk of treating versus the potential benefits of treating, and then the testing becomes secondary, just for people who either don't respond or who can't get proper treatment in very early on. Now, that also doesn't explain the people who have had chronic fatigue symptoms and lingering fibromyalgia symptoms, or tendonitis, or brain fog, or headaches, or all of the other hundreds of constellations of symptoms that Lyme patients get. So in that case, the trying to approach, how do we do this most effectively and also most economically? If the economics are not the overriding concern, I just spoke with one of the head scientists at IgeneX today, actually, on this, and she said that unfortunately there's no longer that Australian panel that IgeneX used to have, but that the tick-borne disease panel 6L, TBD 6L, but to me that one's very expensive, and to most patients that's going to be expensive, and it's great and it's complete, and you can't really beat it, but that's not really practical for most people. That's so what I typically do in my practice, because I don't run huge panels, I try to cherry pick, because where in America, where we don't have healthcare that's covered typically by insurance or by the federal government, and most often not by insurance, especially when we're practicing Lyme. I'm hoping that if the patients are going to use their resources, that they're going to use it to get better, not just for the diagnostics. So I really try to hone in on the testing that's necessary. That being said, I think that if at a minimum, what I'm typically going to do is a Lyme immunoblot IgM and Lyme immunoblot IgG. That's going to be the basic starting that I'm going to look at. And that turns out to be to do those tests for about $450 US. So $225 each. If you do a panel of things, it does, the price does go down, but sometimes I'll do those tests. And here it's a little bit easier because I can just send the blood and shipping is paid for. And then if something's negative, then I can repeat testing, where there's a lot of moving parts to get the sample spun and then shipped to IgeneX in time. Then that it's not super practical to do one test, wait for the results, and then do another test. But that being said, the very minimal testing that I would do for bog standard Lyme would be the immunoblot IgM and IgG. Now, the caveat to that is that one of the studies several years ago showed that various species of tick-borne relapsing fever Borrelia were as prevalent or more prevalent than Borrelia burgdorferi, the one that causes Lyme. So there is a little bit of cross-reactivity, but the TBRF testing immunoblots also may be quite appropriate. And so then it's like, okay, well then is it practical to do all four tests, the IgM and IgG, for both Borrelia burgdorferi and for TBRF? That's without speciating them. And so what I'll typically do if I really want to know is I'll do, because to me, the test that's the most important for an active infection is the IgM. IgM is very confusing for people who aren't involved, very confusing for practitioners who aren't involved in treating Lyme and a few other infections, because we usually think of an IgM antibody response as a new infection, as a new response. And it's true, it is the first response, or first B cell or antibody response that we'll make. And what happens is, because it's a large molecule that gets broken down fairly quickly, there's most of the IgM that's initially made in response to an infection or to a vaccine or to whatever other thing we're reacting to, it will usually go away after 3 or 4 months, usually 4 months at the maximum. And typically before it goes down all the way, the body will create an IgG response. And those IgG antibodies are really memory cells. And that's usually how we determine if someone has been exposed in the past. The problem with this is that an IgG in general doesn't tell us active infection. Like we'll see this with Epstein-Barr or herpes infections or chlamydia pneumonia infections, or all of these infections where most people, even on the planet, are going to be IgG positive to some degree or other to those various infections. But it doesn't really tell us if one is actively infected. So the key piece here is that in Lyme, and it seems in relapsing fever Borrelia too, but the evidence isn't quite as compelling, from a literature standpoint as it is with Lyme, but that the IgM will persist. And that it does get broken down after 3 or 4 months, just like most IgM does. But if the infection is still present, for many people, it will appear again. And so if you could do serial IgM immunoblots, you would see like a sine wave pattern where it goes up and then it goes down for a few months and then it comes back up. There's been a lot of ideas of why this is true, partially due to the intracellular nature of Borrelia, partially due to the spirochetes themselves, that they can have various antigens on their surface, these different protein tags that the antibodies are reacting to, and they switch, the Borrelia organism will switch which antigens or which proteins are on its surface. And so it'll continually look to the body like to the host, like a new infection each time. And so as a result, there'll be different banding patterns, but it'll be a persistent IgM pattern overall if you check the timing right. So for my purposes, if I was going to eliminate anything, then I would eliminate the IgG. It doesn't get, the IgG is important, and for I guess academic purposes, but not just academic purposes, it's useful, but it's not mandatory. The IgM, I think if there was going to be one mandatory test, would be the immunoblot IgM. And if I only had that kind of money to spend, then I would do an IgM immunoblot for Lyme and an IgM immunoblot for tick-borne relapsing fever Borrelia, if I was in Australia. Now, and then where the tricky part is that there is each person's Lyme has a certain flavor, right? So some people are going to have pain. Some people are going to have headaches and night sweats and vivid dreams. Some people are going to have neuropathy. Some people are going to have GI issues, psychiatric symptoms. And what we often find is that these various co-infections, these other organisms that the ticks also will transmit or co-transmit, or transmitted another time, and then become synergistic, as it were, with the Borrelia. Each one of those has its various symptoms that are typically associated with it. So if someone presents with major body pain, fatigue, liver enzyme elevation, and a low white blood cell count in the presence of a likely tick bite, I'm going to look for one of those rickettsial infections like Anaplasma or Ehrlichia. So I'm going to do antibody testing for those, because the antibody testing is pretty good for that. And if someone comes in with major GI issues or neuropathy or strange rashes on their back or significantly swollen lymph nodes, then I'll do a Bartonella immunoblot, sometimes what's called a Bartonella fish test, which is an RNA test, similar to what the T-Lab does. T-Lab also uses a Bartonella fish type technology. And so this is but the IgeneX one it's an incredible, actually looks at the RNA lit up on a slide. And it's quite a good test. And then the Bartonella immunoblot is also quite effective, and it speciates the different Bartonella species. If someone has major pressure headaches, vivid dreams, air hunger, shortness of breath, significant night sweats, or major neurologic symptoms, then I'm going to look at Babesia, and then I'll do a Babesia antibody or Babesia fish, maybe a Babesia PCR, which is a DNA test. So I'll add those to those base panels that I'll do. None of those, I probably wouldn't do those if I didn't have some likelihood that idea that someone had Lyme or tick-borne relapsing fever, Borrelia. But it's really, I think, important because the treatments are so different. I guess you could argue that with rickettsial infections, with the Ehrlichia and the Anaplasma that I said first, because the main treatments for that would be a tetracycline class drug, that if you're going to use that anyway for treating a Lyme infection, you could argue that, well, they may have it. I don't need to necessarily know in the chronic phase. In the acute phase, it's important if someone's really sick, because you need to make sure that you get the doses right and maybe add the right other secondary medicine if there's a bad Ehrlichia Anaplasma infection. But with Bartonella, the treatments are different. With Babesia, the treatments are different. So it's important to know has those infections.
The company. Looks like he's in trouble.
Too many moving parts. Sorry.
It's okay.
Okay, sorry. So the co-infection testing that the various panels offer are remarkably useful, but I don't do those typically as a broad sweep, and definitely not with everybody. I typically, in my practice, I'm going to do establish if there's lab support of a clinical diagnosis, and there's definitely people who aren't going to test positive for Lyme, and there's tricks that we can do, but it's an iterative process where, like, if someone's negative on their immunoblot IgM, well, it could be because the organisms are either in phase or they're in their down phase because they just were IgM positive. One of the things that seems to work is, and actually does work, for bringing out, as it were, a positive IgM, is treating someone with an antibiotic that goes inside the cells, an intracellular acting antibiotic, and then strategically, like 3 to 4 weeks later, then testing another immunoblot. So one could do, let's say you do an immunoblot, IgM, tick-borne relapse fever, immunoblot, IgM, both are negative, but some has symptoms, and you have a real suspicion this is likely. You do a 10 to 21 day course of doxycycline or tetracycline or minocycline or azithromycin or roxithromycin or clarithromycin or one of those, and then 4 weeks after starting treatment. So if you're just doing 10 days, then 3 weeks later, and if you're doing 3 weeks, 21 days, and 9 days later or so. But 3 weeks or 4 weeks after starting that antibiotic challenge treatment, then you repeat the immunoblot. And many times it'll turn positive. And I usually do that when I see indeterminates for some of the various bands. And it seems like it's not quite a positive, and I want to get a positive sometimes. On the other hand, with the IgeneX spot, which is a T cell test, or Armin's T cell testing, that's not looking at antibodies. It's looking at T cells, at the chemicals that sensitized, primed T cells. It's another kind of a white blood cell would make against an infection that it's been exposed to. So that testing can also be done in the absence of a positive antibody test. I think the antibody testing is preferred as a first start, but if you can't find antibodies, sometimes doing the T cell testing can be really useful. So I do the T cell testing quite a bit as well. And then, of course, DNA testing is amazing. The DNA testing, it doesn't lie. I used to argue that, well, does it mean that there's an active infection? You know, we've seen this with COVID, is that people are PCR testing, for weeks, sometimes months after the infection, and this from the persistent antigen doesn't mean that there's active infectious particles, right? But the PCR, it's not really like that so much for Borrelia. So doing a DNA test for Lyme, if it's positive, very helpful. If it's negative, not really helpful at all, because Borrelia doesn't actually like to live in the bloodstream so much. So there's definitely some tricks about it. There's antigen testing as well. Antigen testing is actually looking at these specific proteins that are on the organism, and sometimes if you do a heavy provocation, which would be like a 5-day provocation, with a few different antibiotics, such as a cell wall drug like penicillin or amoxicillin, or a 3rd generation cephalosporin, whether it's oral or parenteral. Usually I'll do IM, like ertapenem or ceftriaxone or something, or bicillin. And then so do that plus an intracellular, like the azith that I spoke about before, plus what's called a cyst buster. You do those for about 5 days, and then you collect urine strategically, like days 2, 4, and 6. Oftentimes people will shed antigen out of their urine, and that's also very helpful. So what I'm talking about here is indirect tests, which are looking at our immune system. That would be the B cell, T cell testing. And then we're looking at direct tests, which would be the DNA, the RNA for the other organisms, and then or the antigen for Lyme. And so that's usually the body of testing that I look at. So if you're stuck and money's not an object, then I'd say tick-borne disease panel. 6L is the big one. 4L is the one that also covers everything else that we see in Australia, and then or the individual tests. And then if I was going to go bare bones, I would do immunoblot, IgM for Lyme, immunoblot, TBRF, IgM for for tick-borne relapsing fever, and then based on the symptom complex, and you can read about it. A lot of people spoke about it. Joe Burrascano has done work on this, Rich Horowitz, and a lot of there's been a lot of talks in ILADS and Lyme Disease Association, and various papers about it by ILADS docs have discussed the association. It's not guaranteed, but the association of various symptoms with each co-infection. And so based on which symptoms seem to fit, then I would consider looking at those co-infections.
Awesome, Dr. Harris. And I know we have a time constraint today. So just in completion, is there innovations coming? Is there hope for patients for better testing and diagnosis in the future?
Culture could be coming. Culture might be, and culture is the gold standard. Culture is where it's at. If we can grow those organisms, then it's really hard to dispute that. There's some interesting other kinds of DNA, RNA fragment pieces, protein analysis, these microarrays that various people are doing. So there's some really neat technology on the horizon that can be done without actually having to send samples, or can be done on little plates with a chip and run through a machine. There's definitely some things in the next 3 to 6 year horizon, maybe even earlier, that will really, if the specificity is there, it looks like the sensitivity may be high enough. So that's the thing. I mean, the problem is that the general medical establishment believes that Lyme is underdiagnosed, and that the labs report too many positives. But the reality is that they don't report enough positives, and it is definitely underdiagnosed. We finally have acknowledged it in the last several years, because the Center for Disease Control here, so there was 30 to 35,000 new cases a year, and now they're saying, well, even though people are just testing positive 50,000 times, we think there's probably about 500,000 new cases per year in the States alone. And those people are not getting, that's probably another discussion, but not getting enough treatment. So many of them are positive the following year still. But yeah, there's hope. I mean, I think that the issue is the political will needs to be there. It has to be grassroots. Patients have to take their health in their hands and not believe necessarily that the authorities know what they're talking about, because a lot of times we don't. So you have to dig for yourself, or have someone, if you can't, have someone help you dig.
Awesome, Dr. Harris. So, ladies and gentlemen, if you're sick with tick-borne diseases and you want to get testing for IgeneX, this is some advice. We're always here. The LDA is working for you. And I know the situation is dire, but we're not stopping. And I know that Dr. Harris and his team is available. So reach out to us and we'll give you a hand. And Dr. Harris, God bless you. Thank you for being here.
My pleasure.
Thank you.